Deonandan, who is a professor and epidemiologist for the Faculty of Health Sciences at the University of Ottawa. Doctor, thank you so much for the time. I know it's a busy day for you. Thanks for spending some time with us.
Oh, thank you for having me.
Uh, where do we begin here? These are the worst numbers we've seen. We knew there was going to be a third wave. I mean, we're in a crisis situation here right now. What should we be doing that we haven't done so far?
Well, that's a good question. We got to pull out all the stops, right? And so right now we have a stay-at-home order, which really is just our gray zone minus the indoor dining. So what we should be doing probably is closing all non-essential businesses and making sure we have economic supports for those people. That's the other half that really has to be looked at. We can't have people economically suffering from this. All of these endeavors are just disincentives for human behavior. Keep that in mind. This is just ways to prevent people from interacting. If we could do so voluntarily, that would be great, but clearly we can't. So closing non-essential businesses, non-essential retail is important. Moving all shopping to curbside pickup or delivery, except for those people who clearly don't have cars or cannot manage that sort of situation. I think we have to have a province-wide school closure. That's controversial, but it has to be considered. We have to redeploy vaccinations to places where that has the biggest bang for its buck, at least in the short term. We have to have paid sick leave, absolutely. We have to use rapid testing to great effect, like we do in England and France. And we have to do limiting domestic travel, I think, is important here too. We can't have people going from hot zone areas to lesser hot zone areas. Maybe you can't have indoor dining in Toronto, but doesn't mean you can drive to a small town and enjoy indoor dining there. We also don't want to have spread of the P1 variant, which is clustered in some places now. And if we can slow that spread, the better. Remember, this is all about slowing the transmission to give us time to vaccinate. That's our plan right now.
It's the protocol you're describing there sounds very much like what New Zealand and Australia did during the first wave. And I remember talking about that on the air at the time, Doctor, and I had people calling and emailing and saying, this is draconian. How can you do this? We have rights. There was one story about a guy that was walking his dog around the block and got a ticket. Said, you're not supposed to be out of your house after a certain time of the day. And he got a ticket for it. And we said, how could you do that? But it worked. As draconian as some people described it. I mean, New Zealand has not had a second wave or a third wave. They're not just flattening the curve, they've just about eliminated the curve. Australia's had very great success with this too. But they did everything that you just described and said, I don't care what you think, this is what we need to do. Does this government, do we, as the public, do we have the will to be able to do that now?
I don't think we have the will to approach COVID zero, which is what New Zealand and Australia did. We do have the will, though, to do this for a couple of months to prevent catastrophe and, again, to buy us time. So what's different this wave than previous waves, other than the fact that the new variants are posing this incredible threat, is that we have an exit ramp. We didn't have that before. Like a year ago, when we suggested going for COVID zero, like last June, their response was, we can't live like this interminably. Well, now we're not asking people to. We're just saying, just for a couple of months, because vaccines give us a way out. We can join this ramp to normal starting in the summer if we just slow things down right now. Looking around the world, as you know, the places that have done this well all have three things in common. One, they acted early, they acted hard. Number two, they got really good at detecting cases. And number three, they patrolled their borders for reinfection, meaning they controlled travel and the spread of the disease. We can still do that. And the places that have attempted a more balanced response, as we call it, have all suffered incalculably. So to me, it's pretty clear what has to be done. We got to take the short-term pain with, again, supporting those people who are going to suffer the most and allow us to enter that ramp to normal in a couple of months.
That last part that you mentioned, and I know it's the second time you mentioned it in our conversation, but it is a key part to this. Those countries we just talked about, New Zealand and Australia, that were successful in doing this, had all those support mechanisms in place from day one. Paid days off, sick days off, and things of this nature, and of course support for businesses, because you can't do one without the other. And we seem to be doing things in kind of a piecemeal fashion here right now, which I think is confusing to the public, and certainly is probably, as you've described, Doctor, pretty much ineffective in trying to do what we're supposed to be doing here. You talked about COVID zero methodology. We're into mitigation methodology, and as you put on Twitter the other day, this virus is pretty smart. It's outsmarting us right now.
Yeah, I mean, mitigation is tempting, and if we didn't have vaccines, I would argue that maybe we need to find a way to quote unquote live with the disease. Like South Korea, Japan, and Taiwan did. They use extraordinary public health assets to allow nightclubs to stay open and things like that. That could have been us. And it still might be yes if we crush this wave and deploy those assets for a few months while we enjoy vaccination. But again, the great confounder here is public will and political will, frankly. We need both of those to get through this. I think maybe the public will might be there more so than it has been in the past because of the exit ramp, right? It's not interminable anymore. Now there is actually, a dawn over the horizon that we can see. We just have to be able to get there, keep our sensibilities intact and get there. And people, I think, are more willing than ever before to tighten their belts and to sustain the hardship to prevent catastrophe, frankly.
But there's no vaccine against irresponsibility, and it's easy to blame the government. Boy, there's more than enough culpability there about vaccine rollouts and everything. But we have a role to play here. I mean, the public. And I look at the Grey Bruce example. It's been in the news for the last 48 hours or so. Public health officials up there are saying one of the big things, there were house parties, Easter parties, which we weren't supposed to have, but here we are 2 weeks after the fact, and boom, we're seeing a rise. And people were lying about contact tracing. I mean, if we can't play by the rules, I mean, we're going to be victims of our own bad behavior, aren't we?
Yeah, this is the great failing of our greatest strength. Our greatest strength is our freedom, our liberal democracy. It's also our failing because people do have the ability to lie and to misrepresent and to put their own personal needs above the collective good. Around the world, again, those countries with strong authoritarian tendencies did better, unfortunately. What I like to think, though, is at the end of the day, our liberal predilections, our small L liberal predilections, our desire for freedom and innovation will win out because that's what allows us to have things like vaccination. But you're absolutely right. Personal responsibility is at the heart of this. And I don't want to be that scolding person who says, hey, you young kids out there partying, stop it. I want to remind people that a lot of people, especially young people, can't physically distance because there are essential workers and baristas and they live in crowded settings. But also, there's an element of heroism here that we can stress. Instead of always hitting people with the stick, with bylaw infractions, we can express to them there is heroism to be wrought here by protecting your fellow citizen and by making sure we enter that ramp to normal quickly. So the incentives, I don't think, have been well communicated to people yet.
There's, I guess, two tacks here, are there not, Doctor? I mean, you've talked about, I was going to call it the long game, and maybe it's not as long as we had thought it was because the vaccines are there. We just, it's a matter of numbers now. But there's the here and now, and I'm concerned about that, and I know you are too. I've seen some of your comments over the last couple of days about these rising numbers, and we mentioned at the beginning of the conversation, they're higher now than they ever have been with any of the waves that we've endeavored. How do we handle this? It's almost as if hospitals are being overrun. I mean, as we've been reporting, I mean, we're putting people in pediatric hospitals, in long-term care, anywhere they can find a bed. That's if they can find a bed, but that doesn't necessarily mean they're going to get the level of care that they should be getting right now. Is it time to call in the reserves? Is it time to get the military? Is it time to get some help and relief for the frontline workers that are pretty much exhausted right now?
This is a supply problem and a demand problem. We have demand for service and insufficient supply. Now, we've talked about how to reduce demand by slowing transmission. And by the way, we have a lot more play in slowing demand, whereas increasing supply, we don't have much of an opportunity here. Our ceiling is quite low. So the rate limiting step there is, frankly, healthcare workers. We can build more beds, we can build more hospitals, we can probably buy more ventilators and things like that, but we don't have enough ICU nurses and physicians and people like that, and respirologists, to staff them all. The way this is going to play out is there isn't going to be a magical day when suddenly things don't work anymore. It's going to go step by step, insidiously, slowly, bit by bit. Care will diminish because our healthcare workers, heroic as they are, will stretch themselves thin. We'll have people in hallways. We'll have ICU beds staffed by fewer and fewer people. So the death rates will climb, not just for COVID, but for people in hospitals for other reasons. It's going to be an insidious situation that the public will not perceive at first, unfortunately. So to answer your question, what do? Well, we slow demand. And we increase capacity as much as we can, and that probably means importing healthcare workers from lesser affected areas, maybe retasking other healthcare professionals to work in an unideal situation. But that has limited capacity as well. Human beings can only exhaust themselves so far. So our best bet is slow demand, slow transmission. That's the only way we can survive this.
Doctor, do you get the sense that we, again, in the public, understand the depth of the concern here? We don't all walk up and down the halls of hospitals So we don't see what's going on. I mean, we hear statistics, and as a matter of fact, I wanted to address one other thing too. I mean, you've seen a lot of the stuff on social media right now that says, look at all these numbers we're hearing about on the news. They're all overblown. They're overstating the number of people that are impacted by this. And I know you've got some pretty strong thoughts about that.
Yeah, the disinformation is really problematic. So people are saying, hey, we're at 80%. That's not so bad. But we're at 80% because we keep creating more capacity by artificially moving people out of hot zone areas, or people die. You know, every time someone dies in an ICU bed, guess what? That's a spare ICU bed that pops up in the data. Or we have asked nurses to cancel their vacations or work a few extra hours per day. So artificially, the numbers look better than they actually are. So beware this kind of reporting. This is probably the worst crisis I've ever seen the healthcare system sustain since I've been looking at it. I'm not a physician, I'm a PhD, so I don't get to see this firsthand. I look at the numbers. But my colleagues tell me that they are really taxed. The way it's going to affect the common citizen, though, is if you are in a car accident or have a heart attack or need emergency care, your care is now compromised. Your chances of dying are now higher than it was last week, regardless of COVID. That's why we should care about this. Each of us is impacted by these statistics in a profound and meaningful existential way. Do not doubt that fact.
We've seen this. This is art imitating life. I guess we've seen this in some movies, war movies. I think it was Saving Private Ryan and a few others. We saw a medic walking all the way down, save him, not him, not him, save him, save him. It's triaging, essentially, to say, okay, that one's worthwhile, this one's are we getting toward that point now? Because it's a scary proposition, but I'm hearing a lot more talk about it.
Yeah, I think we are getting towards that point. And Dr. Michael Warner, who's been such a fantastic leader in all this, was tweeting earlier about the actual rules. You cannot remove someone from care, but you can deny someone care. So if someone is already occupying a bed and someone else needs it, you can say, you can't have that bed, it's filled, therefore you will suffer. So we may have to revisit what the actual ethical rules are around all of this. It's a horrible position to place our healthcare workers in. They should not be making these kinds of decisions. A society should be making these decisions. And frankly, we should not be putting anyone in the position to make these decisions. Therefore, it is incumbent upon all of us to prevent that scenario from playing out. We definitely see this in other parts of the world, without question. And how do you make that decision? Is it the youngest person gets the service? The person most likely to live gets the service? The person who got there first gets the service? The ethical questions are deep, but we can avoid it, but of course, by reducing demand again. So I hope that our leaders make the right decisions in coming days to help slow transmission. And more importantly, I hope that our common citizens, our fellow citizens, make the decision to voluntarily reduce our individual exposures for the greater common good.
Dr. Yaffe yesterday was talking about the dire circumstance, using pretty strong language about this, and again suggesting that it's probably going to get worse before it gets better. We seem to be in a cycle right now of living in 2-week increments because of the incubation period. We saw these terrible numbers and the projections, of course, that are being released later on this afternoon, which are probably going to be startling as well. Can we expect it to stay like this for at least till the end of this month? And maybe if we crack down, like you're suggesting today, that we might see some improvement maybe by the end of the month?
Yeah, I think it's going to climb for a bit. And I think if all goes well, we'll peak in early or mid-May and come down after that. That's the projection that I'm looking at. But again, none of us has a crystal ball. If the right measures come into place, if we prevent the new variants from further colonizing our population, then we can start seeing numbers come down sometime next month and then enter that ramp to normal in the summer. But we are playing here with the possibility of a fourth wave, which is a horrifying thing to consider. I think people are seeing American TV and seeing how well they're doing in terms of their vaccination deployment and penetration and assuming that's us. That is not us. We don't have that level of vaccine availability or that level of uptake, frankly. So we have to consider the Canadian case, the Ontario case, and realize we are now the worst COVID example in North America, believe it or not. Depending on how you look at the numbers. So we got to get ourselves out of this. But we have a shot at it. The window is closing, but we definitely have a shot at, again, that ramp to normal. So what I want to see is the urgency in people's eyes, as they look at these numbers and recognize that there are things that we can do individually to help this process along and reclaim our lives in short order.
I'm glad you brought up the U.S. Analogy here too, because I think there's a lesson to be learned from that too, isn't there? Their vaccination program is doing exceedingly well, beyond all expectations, and that's good news for them. But their new cases are going up nonetheless, which tells you the vaccine is not the be-all and end-all answer. If you're not following the other protocols, you're still going to be in trouble.
That's right. The numbers will come down once we reach a certain level of population immunity. And they won't magically come down. It'll take time, as Israel showed us and the UK showed us. These mitigation tools that we have, mask wearing, distancing, limiting our social gatherings, are important. They will be lifted one by one as time goes on, but they cannot be lifted all at once. Vaccine is not a panacea. Vaccine is the single best mitigation tool that we have. In coordination with other mitigation tools, they will crush community transmission. And when that happens, we lift all mitigation tools. So the lesson I want people to understand is none of this is interminable. You don't have to live like this forever. We aren't going to be masked for the rest of our lives. We just have to deal with this now in short order and allow the vaccinations to do their job. We have role models now in Israel and the UK and other places. We just have to do the needful.
Doctor, always great to get your perspective. Thanks so much for spending some time with us. Stay well, and hopefully we can talk again soon down the road.
Thank you for having me.
Take care. Dr. Raywat Deonandan, of course, from the University of Ottawa.